Hi doulas! Alright, so this is installment number 2 in our induction series. Because inductions. That's why. That's why we're doing the series. Because inductions, not always super easy and fun. And so here are some of the things I want to chat about today. Number 1, we're going to start with chatting about just changing plans. When plans change. My least favorite, top 5 for sure, least favorite word in the birthing world is the word birth plan. I hate the word birth plan. Why do we keep using that? Don't we know better by now? You can't plan birth. You cannot plan birth, people. What we can have is birth preferences. We can have birth preferences. And so I never use the word birth plans. I only use it in the context that my clients use it. And then I switch the wording around and then we talk about birth preferences. And if you meet even only 2 or 3 times with people and you switch the language from birth plan to birth preferences, what you're going to see is a change in how we perceive the notion of planning our birth versus having preferences for our birth. And of course we need to have preferences. But we all know if you've been a doula for any more than, probably 2 births, but realistically 5 for sure, you know that there's so much about this experience that can't be predicted, and that we can do quote-unquote everything right and still end up with a dramatically different experience than what we had hoped for or intended for ourselves. So how do we help people to reconcile the notion of their birth changing, and especially when we're talking about an induction? Now imagine that client, and these are always the toughest ones for me personally. It's the ones that are imagining this home birth, a home water birth with their midwives and all their friends and family and all of these things, and then all of a sudden they develop preeclampsia, early into their 3rd trimester and are faced with needing an early induction. I mean, that's a pretty dramatically different birth experience than what they had imagined for themselves. And what my goal, listen, I have 2 goals for people. For my clients, I have 2 goals. I want to increase confidence and reduce anxiety. That is what I want from my clients. And that's what I want for my support to be able to do. So when someone is faced with an induction, the wording that I use, the language that I use, the conversations that we have are very much based on how can I reduce anxiety and increase confidence. And one of the things, admittedly, that I really dislike is when people say, I hear people say, oh, I really, really didn't want to be induced, but I had to. And I always wonder, what does that mean, I had to? And the interesting thing about that comment is that people are often placing themselves in a victim role in that storytelling, where all of these things were done to them. So I'm going to tell you a really funny story, amazing story that I had many, many years ago. I had a client who was 35 weeks pregnant and went to a midwife appointment. So she was planning an unmedicated birth and possibly leaning towards a home birth, but definitely very keen on an unmedicated birth. And she goes to her midwives at 35 weeks and they say, we think this baby might be breech. So we're going to send you for an ultrasound just to confirm, but it's probably fine. So when they did the ultrasound, what they realized was, yes, indeed, the baby was breech, but not only that she had very low fluid volumes. And they were concerned. So they were recommending an immediate cesarean. Now that day was particularly busy at the hospital. And so, of course, I went and met them at the hospital. We asked a lot of questions of the obstetrician on call. The midwife came. We had a big conversation with the midwife. And pretty much what we were hearing was no options. And that's often what our clients hear, isn't it? They hear there are no options. And so she went home that night, and the plan was, it was really, really busy day at the hospital, so they couldn't actually fit us in that day. So they said, go home, come back tomorrow morning, we're going to do a cesarean in the morning. So I meet her at the hospital first thing in the morning. Her whole face is puffy. She's been crying all night long. She's so upset about this cesarean. And so we're having a good conversation about it, what's upsetting to her, and she just really feels like all of this is being done to her. Now, this was many years ago, and I don't know, looking back, if maybe I didn't facilitate the right types of conversations. I was much newer as a doula back then. I'm not really sure exactly how that went. What I do know is that we kept getting bumped because this wasn't an emergency. We kept getting bumped because it was a really, really busy obstetric day. Eventually, the obstetrician on call comes in, and she's been working so hard that morning, she actually has sweat on her brow. And she sits down in a chair. She slides a chair up to my client's bedside, and she puts her arms, crosses her arms over herself, and she goes, "I hear you're not happy about this birth, this cesarean." And my client has been crying for so long. She's actually like, you know, doing that thing where she can barely speak and catch her breath. And the doctor says, "Why are you so upset?" And my client, you know, explains her reasonings. She was very different than what she was planning, and, you know, the baby's little, and all of her worries. And the doctor says, "Listen, I do not want to drag you down this hall kicking and screaming to have a surgery that you don't want to have. You do not have to have this surgery. I'm telling you, I think it's a good idea because, listen, I can't predict first of all, I don't know why your fluid levels are low. And because I can't predict what's going on in there, and it's still pretty early, but your baby's doing really well, I don't want to take a chance. Your baby could be good for a day, though. Your baby could be good for a week. Heck, your baby could be good for a month. But because I can't predict that, I'm uncomfortable taking a wait-and-see approach. But if you feel certain that your baby is perfect in there and totally fine and you don't want to do this, you do not have to do this." And I remember looking at the clock at one point, going back and forth, the client and the doctor, and this conversation went on for 20 minutes. We literally could have had a baby by then. But that's how much time this doctor took to provide a truly informed decision-making situation. It was amazing. It was so amazing. It was up to that point, one of the most unbelievable moments of informed decision-making and informed refusal that I had ever witnessed. So what happened, of course, is when the decision was put back in my client's hands, she decided, "Oh, I don't think I want to take a risk either with this baby," and that she wanted to go ahead with the surgery as planned. But her feelings about it completely changed. Now, as a side note, because some of you are probably wondering, why couldn't she be induced instead of cesarean? Well, they don't induce breech babies there, and they couldn't do a version because she had an anterior placenta, so they weren't able to turn the baby because of the positioning of the placenta. So just as a side note, we'd kind of explored all those options. But what I realized was that when the decision was put back in my client's hands, it changed everything. And from that moment forward, what I started saying to clients is, "Listen, I can guarantee you one thing about your induction that's being proposed that you don't want to have. No one is coming to your house to pick you up for the induction." And what I want my clients to realize with that is that the decision is ultimately theirs. They don't have to do it. Now, are there good reasons to do it? Well, probably, or at least in that care provider's minds, there are very good reasons. What we want to do and what we can do as doulas is get our clients to that point where they think the reasons are good enough, so that they come away from this birth experience feeling like it wasn't done to them, but it was being done for them, that they were part of the decision-making process. And we know that that's one of the top factors that lead to birth satisfaction, is when people feel like they were well supported by the people around them and that they were an informed decision maker in their care. All right, so now, separate from that whole concept of changing plans and working with our clients to make sure that they're comfortable with what's happening, the next thing that we always have to do is work with "and then what?" questions. So let's say they say, "Okay, I agree that there's a reason for this induction, but I don't want to be on continuous fetal monitoring." Well, in almost every place I've ever heard of, an induction involves continuous fetal monitoring if there's Pitocin involved. So then we can talk to our clients about, hey, is there a way we can avoid Pitocin? And if not, okay, we're on fetal monitors. Well, what does continuous fetal monitoring mean in that particular hospital and in that setting? Because technically, in many sort of clinical guidelines, continuous monitoring could be 30 minutes on and 30 minutes off, or 20 minutes out of every 30. So that kind of makes a big difference, doesn't it? Can we negotiate what continuous monitoring means? And even if we have continuous monitoring, listen, I'm at births all the time. We're on balls, we're on hands and knees, we're using squatting bars, we're all kinds of different positions. We're doing slow dancing, we're doing all kinds of different things with continuous fetal monitoring. Now, the one thing that I will say about changing positions frequently with continuous fetal monitors on is that, of course, whenever we move or if the baby is moving a lot, that it typically starts to not catch the baby. And listen, I know it's super annoying when you feel confident and everyone feels confident that that baby's really, really fine and the heart rate's good, but it keeps shifting and catching the birthing person's heart rate instead of the baby's heart rate. Because of course what that looks like on paper is that the baby's heart rate's dipping, even though everyone involved might know that that's not what's happening. So what I've often done as doulas, and this happened to me at a recent birth actually, is I just sit there. If the nurse is okay with it, I'll sit there and hold the monitor when my client's in a specific position to make sure that the monitor is catching. Because of course what happens oftentimes is it's such an imperfect science, right? So the monitor, it might just need to be pressed down a little bit more into the abdomen for it to catch the baby's heart rate well. And as soon as everyone lets go, all of a sudden it doesn't catch. And as soon as the nurse pushes, then it catches, and the nurse lets go and it doesn't catch. Well, if the nurse has to walk away and do some charting or something, then what I might say is like, hey, is it okay if I hold that there just so that, this doesn't become an issue? And that's usually totally fine with the nursing staff in my experience. So that's one way we can get around that. There are very rare circumstances where people really, really, really have to stay in bed. And ultimately, if a client says they don't want to stay in bed, they can get up, they can move around, or stay in bed and try different positions, side to side, and hands and knees, and do different things. And this is where our clients need to advocate for themselves too, to be able to move around and do what they need to do. One of the things that I often recommend is that a client maybe chooses not to put on a hospital gown. And the thing about putting on a hospital gown is it sure does put us into that patient situation right away, and it makes us feel like a patient. So if we can avoid a hospital gown and keep our own clothes on, sometimes people feel more confident in making their own decisions when that's the situation. All right, so one of the other things that really kind of frustrates people when birth plan switches to an induction is they often feel like they can't use the bath or shower anymore. And you know what, in my experience, most inductions that I tend to attend include some form of aqua water therapy at some point. So what it is a little bit of negotiation where we might say to the nurse or midwife, hey, what about 5 minutes? What about 10 minutes? What's the most amount of time that you're comfortable being off the monitors? And if the baby's doing really, really well on the monitors, from a heart rate perspective, then often 5, 10, 15, even 20 minutes sometimes, is totally reasonable and still considered continuous fetal monitoring. Okay, so it's not helping our clients to realize that it's not all or nothing. It's not, completely unmedicated, this perfect birth that we envisioned, or this horrible induction. It doesn't have to be like that. It's just changed and different plans. It's not necessarily a bad plan, it's just different. So one of the things, of course, the reality of many, many inductions where Pitocin is involved is that at some point our clients typically will want an epidural. And there's so many reasons for that, which I'm not even going to get into. You guys can do a lot of research, but when we look at the hormones that are involved in labor, of course, the hormonal physiology of birth is different when we are induced. It is not the same normal hormonal physiology. And so there's so many things that are happening differently with us and with our baby when we are induced artificially. So some things that we need to consider are that the endorphin level isn't the same as when we go into labor naturally on our own. So what typically happens when we go into labor on our own is a little bit more pain, more endorphins, more pain, more endorphins. Remember that endorphins are a natural morphine-like chemical that our brain releases to help us cope and feel good. So as we increase more pain, more endorphins, more pain, more endorphins, of course, that happens in a natural labor. Now, when we all of a sudden start Pitocin and that pain level might start significantly higher than it would have on its own, the body doesn't respond in quite the same way hormonally. And so those endorphins, they never really catch up the same way. And so people tend to use medication more commonly in an induction, a Pitocin induction specifically, than when they go into labor on their own. So what can we do about that? What about the people who want to avoid medication, who are really, really committed, or maybe you're working with a client who can't have an epidural for whatever reason. So here's some things to think about. One is to see about negotiating, having the bag of waters broken, and being given some time to start labor on its own, to start those contractions naturally before starting with Pitocin. The other thing is if there's ability to negotiate those Prostin pills to bring on contractions instead of Pitocin. Now listen, I haven't seen that in years happen, but it doesn't mean that it can't happen where you are, okay? So that's another option. And then the third option is, looking at what other types of medication are available in that client setting. Maybe, although they wanted to avoid an epidural or they can't have an epidural, maybe a narcotic is an option for them. Maybe nitrous oxide is an option for them. So just considering some other things that might be available for pain management. And inevitably, a lot of our clients are going to end up with epidurals. So what do you do when a client has an epidural? You know what? I think that's good for another post at another time soon. I'm not going to get into that too much right now. What I would suggest to you is that I know inductions can be really, really long. And a client might be only 4 or 5 centimeters and they get an epidural at night and you think this is going to go all night long. But listen, a lot of times it doesn't happen that way. And so I very, very strongly discourage you from leaving a birth. Find somewhere to sleep, yes. Your client is sleeping soundly, their partner is sleeping soundly, absolutely sleep at the same time. But don't leave. My suggestion to you. And then the other thing I think that's really, really important when we think about inductions too is checking in with the partners and other family members. How is the partner doing? Are you constantly checking in with them as well and making sure that they're okay? If your client, let's say, gets an epidural and goes to sleep, that's a really great opportunity for you to take a food break for sure, but can you get the partner some food? Do your clients maybe want you to go into the waiting room and give their family members an update? That's obviously not top of mind for them in their own labor, but maybe those people are really, really important to them and keeping them up to date is important. So that's typically something that I'm going to chat about in a prenatal visit so that I know what the expectation is of me and what the relationships are like with the other family members that are going to be there. But I think that's a great time for you to, in a long induction is for you to give those regular updates for the family. And then, of course, baby finally comes, and maybe you've been with your client for a really, really long time. And often you might be thinking, oh my gosh, I can finally leave. But the postpartum period is still the same. Whether you've been with your client for 2 hours or for 22 hours, there's some things that we need to do as doulas, right? Other than, did they want us to maybe take some pictures and, of course, providing that emotional support around the delivery of the placenta and any kind of, suturing or anything that's happening after that. But also breastfeeding, making sure they have something to eat before you leave, initiating skin to skin and that early bonding. All of those things that were important to them. I think it's still really, really important for us to put that same emphasis even when our own energy levels are starting to drain a little bit. So just some things for you to consider. In our next episode, I think what we will talk about is a little bit more on negotiating. Let's chat a little bit more on that and how to work with other care providers and other professionals involved in the birth in a way that's respectful and collegial. And I think we'll also come back to talking maybe a little bit more about epidurals and supporting our clients with epidurals. Okay, so until then, see you next time. Bye.